Onc Live Insights is a video editorial program produced by Onc Live.
So testing lung cancers for different genotype mutations is a really important part of practice today, and it's now part of official guidelines to do so. And the idea is that there are many different mutations that can be found in the cancer that might tell us that the patient is a good match for a certain kind of treatment. And so if we can identify the mutation in the cancer and the targeted treatment, put them together, the patient can have really nice treatment options. So these are most commonly found in lung cancer patients with adenocarcinoma. So at this time, the recommendation is for all patients with lung adenocarcinoma to undergo testing. At a minimum, the testing should include looking for EGFR mutations and ALK translocations because there are FDA-approved agents for both of those drugs. But more and more, what we're seeing is that every year or 2 years, there are new advances and new developments as far as targeted drugs that match up with certain mutations. And so what really, in my opinion, makes the most sense for patients is to undergo not only testing for those two, but a multiplex panel, meaning testing for multiple different genes that could be driving the growth of the cancer all at once. When you do a multiplex testing, you conserve the tissue, which a lot of times for lung cancer patients, biopsies are small and tissue is precious. So you can conserve the tissue by testing for multiple things at once. ROS translocations are very important to test for in adenocarcinoma because the drug that's approved for ALK can be used to treat ROS. And there are lots of other mutations that can occur in lung cancer that can be treated with drugs that are already out there approved for other types of cancers, such as BRAF mutations. One question that often comes up is, should we test for KRAS mutations? When you look at, for example, a pie chart of the types of different mutations that can be identified in lung cancer, KRAS is one of the biggest pieces of that pie chart. About 30% of lung adenocarcinomas will be positive for a KRAS mutation. At this time, there aren't great targeted therapies for KRAS mutations. So if you find a KRAS mutation in your patient, it doesn't necessarily trigger you to move them towards a particular targeted therapy. But it still can be helpful because with these different driver mutations, each patient will only have one. And there are some very rare exceptions to that rule, but as a rule of thumb, each patient's cancer will be driven by only one driver mutation. So if you do identify KRAS, you know that that's the driver mutation for the cancer, and you don't necessarily have to go looking for some of the more rare driver mutations. You've identified the driver mutation for your patient.